we should get started. So welcome everyone. Welcome back to those who are coming back. And for those who, this is the first session, welcome as well. So this is Dementia Basics Part 4. As we know, we started a new chapter on behaviors in dementia. And as you also recall, last time we talked about having a handout. So I'm actually, you have a new handout to keep in mind that this is a new handout. You can download it online on the link provided. Or also, you can have a hard copy here at the office, all right? Also, I'd like to welcome everyone online as well. We have a good number of people joining us online. I know it was also very difficult for driving, and also it was very foggy, huh? Anyways, thank you for all those who made it today. And yeah, so we have a very special speaker. So she's Dr. Lisa Sweet. She's very sweet too. Yes. So she's actually a neuropsychologist from Bruyere Memory Program, also affiliate investigator. And without further ado, I will turn over to Dr. Sweet. This is your mic.
My little rodent.
Yes.
Okay, and I don't think I've ever successfully had it clicked. No, I think I usually just hold it, eh? Okay. All right. All right. Well, welcome everyone. So tonight we are starting a new section on the behavioral and psychological symptoms of dementia. So yes, I am a neuropsychologist. I've been at the Bruyere Memory Program. Well, I've been at Bruyere now for 22 years with the memory clinic on and off over the years, and certainly full-time there now, probably for, I don't know, 15 years or so. So I work quite closely with your first three presenters, and I've been doing this talk for quite a few years now. So let's start. There we go. All right. So we're talking about the behavioral and psychological symptoms of dementia. We refer to them as the BPSDs. So you're going to see that acronym come up, and that's what we're referencing. So when people think about dementia, and even when you think of the name of our clinic, we are the Bruyere Memory Clinic. When you think of dementia, there's a lot of focus on memory, of course, and thinking abilities. A lot of people come in and the main complaints are around cognition or memory. And that's, do I have a light? No, I don't have a light. That's an important part. But oftentimes there are other elements that need to be brought out either in an interview or some of the family members and the patient might be very much aware of them and want to bring them forward. Sometimes it's kind of like, well, I didn't really think that maybe was part of this or not. And there's all kinds of things happening beneath the surface that we need to, I think, become more aware of, talk about more, and address better. All right, so what are they? And we're splitting them into, so the behavioral and psychological. When you think of the behavioral symptoms, think of what you can see and observe. And psychological symptoms, think more of what the person could be experiencing. You might see signs of it or manifestations of it, but it is mostly something that the person might be experiencing internally, okay? So some of the behavioral symptoms that are quite significant and prevalent in dementia, and we're going to talk about some of those individually. Agitation is one of them. Disinhibition, so kind of losing the filters a little bit of what socially would normally be appropriate. Repetitive behaviors, verbal aggression, physical aggression, changes in appetite or what the person might prefer to eat or how much or how little. Sleep disorders can be one problem as well. Those are some of the most common behavioral symptoms. Some of the psychological symptoms are apathy. So apathy is an absence of affect, and we'll talk about that. Depression, anxiety, irritability. I can pretty much start every sheet I could probably pre-write, and probably for most of us, even people without dementia. You'll say, is there any changes in personality? Well, she's a little bit more irritable. That's kind of a common complaint. Hallucinations or visual illusions or misperceptions can come up at certain times and in certain forms of dementia. And delusional beliefs or fears that are maybe have a grain, they come from somewhere and something that might have happened, but then lose touch a little bit with what might be more realistic or probable. So those are just some examples of the behavioral and psychological symptoms that we'll be chatting about tonight. So that was a division of in two ways, behavioral and psychological. And you can also divide them up into how they might present themselves. So these changes. So they might be, when I spoke of delusions and hallucinations, those fall under kind of cognitive and perceptual changes in how the person is perceiving the world and interpreting it. You can have motor changes, and that's things like the pacing, the wandering, the repetitive movements, the physical aggression, things like that. Those are more motor. Then you have verbal behaviors that could happen, yelling, calling out, verbal aggression. And then we have some of the psychological symptoms. So the more emotional category, you would put the depression, the apathy, the anxiety, and what we call vegetative, which is kind of just the basic daily living things, changes in sleep and appetite. So these are kind of the same examples that were listed on the previous slide, but just organized by kind of type rather than category, just a different way of thinking about them. And it gives us a framework either way, either by going behavioral and psychological, or in thinking of these categories when we're interviewing people and trying to find out what's going on. If we keep these things in mind, it gives us a sense of what to ask about to see if there's anything that we're missing or overlooking that the person might not have thought to report as being a factor. Just to continue on the notion that it can be they can be under-recognized, these BPSDs, even in so we use what we call the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, version 5. That is the diagnostic Bible that we use. And in that, they use, the new term for dementia is major neurocognitive disorder. To be diagnosed with a major neurocognitive disorder or a dementia, you have to have evidence of significant cognitive decline from a previous level of performance in usually more than one cognitive domain. There is concern then also that there's a significant decline in the person's function. So we have to have both things to meet the criteria to have a diagnosis of dementia: change in cognition and a change in function. And that's the day-to-day activities, usually the higher order, more complex activities: managing your finances, driving, medications, paying bills, things like that. Those are usually the first ones to start being more challenging. If you have those two, and then we can document that there's a loss in cognition, usually by some of the testing that I might do or some of the screening that the physician might do. These things interfere with independence in everyday living. It's not because the person is sick or delirious with something else, so you've ruled out that. And it's not better explained by something else. It's not because they're so depressed, they've stopped caring about everything, because you wouldn't diagnose somebody with depression if you thought that was the cause of the problem. You wouldn't diagnose them with dementia. Well, once you've covered these, you can make a diagnosis of dementia. And these are all excellent. This is the guide for us, but there's no mention of the behavioral and psychological symptoms. So even in this, now there is talk about it throughout the book, but just at first glance, it's not even fully kind of developed in those criteria. So that's why it's an important part of these kind of talks, and it's an important part of all the clinical work that we do, because it can be one of the biggest issues that the patient and the caregivers might face. So how often do these BPSDs come up? Well, very often. And I always say never quote the numbers, the exact percentage, because you could go out and find a study that might quote a little bit of a different percentage. But the idea being is that if you think of the stages of cognitive change or cognitive decline and functional decline related to different kinds of dementias, we might start with mild cognitive impairment, so mild cognitive changes. Then we might progress into the early stage dementia, and then so you have mild, moderate, and severe. And the main message is the numbers go up as the dementia advances. Okay, so whereas you might have 40% of people with MCI who might also be reporting behavioral and or psychological symptoms related to their dementia, that number will go up to about 60% once they cross the line and are now considered in the mild dementia stages. And most people, upwards of 95%, at some point or another, will likely experience one or more behavioral or psychological symptom related to their disorder. Unfortunately, so we know they get usually more frequent and more severe at the more advanced stages, but they can fluctuate. Whereas we can tell people with certainty that if someone has a diagnosis of dementia, and I'll use the example of Alzheimer's because it's the most common one, what we can say is this is a slowly progressive disease. Of that, we are certain. How fast for each person, it can vary depending on a number of factors. It's the same thing with the behavioral and psychological symptoms. We know that the person's dementia will progress, but it's hard we can't predict at which point the person might experience which behavioral symptom, which psychological symptom. Those will be unique to individuals and will change over time. So you might just get used to one behavior or issue and kind of get a hang of it. And you're like, okay, we're coping really well with this. And that might go away and something else might appear. And then you've got a new challenge to face. So they can really change and evolve over time. Many reasons why they are important is they contribute above and beyond the cognition. So somebody might say, I can cope with the memory loss. We've found strategies to compensate for the memory. But when all the other stuff starts creeping in as well, that can become quite challenging. And these behavioral and psychological symptoms, they contribute to further impacting the person's function. So it gets even harder for them to function, even though they might have compensated for memory loss. If they're a little bit more disinhibited and a little bit more anxious, that's going to have an impact on how they interact and day-to-day life. The behavioral and psychological symptoms, when they are there and challenging, they really create stress and increased burden for caregivers. They often, when they're not easily managed, that might be the issue that contributes to seeking placement for someone or an alternative supportive setting rather than just the memory problems. It's the other stuff, which then in turn contributes to higher costs of caring for a person, because then you're often pulling in other specialists, other consults, extra care, things like that. So the BPSDs have a huge impact. And they are very important in terms of the management of dementia. So I was saying that we can't really predict that Mrs. Smith will start to hallucinate in year 3. We don't know. Everyone will have a personal profile. I wish I had a pointer. I don't. They will all have their personal profile, and different things will contribute to creating that personal profile at that point in time. Number 1 might be the type of dementia with which they've been diagnosed. Someone with Alzheimer's disease might have different behavioral and psychological symptoms than someone with Lewy body dementia, than somebody with frontotemporal dementia. It might occur at different stages. So the type of dementia can become important in terms of what we might be able to anticipate at different points. As I mentioned, the stage of the dementia might be important. Of course, the more severe stages, it'll be more frequent. Comorbidities is everything else you've got going on. So if you have struggled with depression or anxiety your whole life, that's going to contribute to that could become a factor when dealing with dementia as well. If somebody has, and it could be medical too, if somebody has uncontrolled diabetes, very terribly controlled diabetes, all those variations in blood sugars are going to affect their thinking, but also can affect mood regulation, energy levels, things like that. So if that's in play, that could affect what their profile looks like. So everything else that's going on with the person. Brain reserve is usually what we mean by how much have you got that you can use to compensate. So somebody who has more reserve, more built-in kind of strategies or abilities or knowledge can perhaps more easily compensate for some of the things going on and might have less BPSDs than someone who can't. We all have a personality. We're all born with it. We all mold it throughout our lives. Our personality might affect how we express the symptoms of our dementia or how our loved one does. Okay, so that doesn't necessarily go away. That can become a factor. And of course, the environment. What is the setting? What's happening? What are some of the stressors, the demands, the expectations, the support? All of that can come into play and mitigate what the profile might look like. So that's why we don't really know. We can talk about the more common ones because they do come up more frequently. You just don't know what the individual profile might look like. Okay? Hop in if you have any questions at all, okay? Don't be shy. All right. So one of the steps is trying to make sense of the behavioral and psychological symptoms. Because if you can make sense of them a little bit and understand where they might be coming from, then that gives you more knowledge, more ability to interpret them, maybe in a way that is less stressful. Doesn't take them away, but sometimes how we interpret something or how we analyze it can make a difference in our own emotional experience of it and how we handle it. So this is just one study that used this kind of structure. So people with dementia are experiencing changes in their brain. So the brain cells, the brain circuitry is not functioning the way it did. It's not functioning normally. So they cannot interact or interpret or analyze or deal with the environment the same way that they used to. So by having that from the get-go, they become more vulnerable to what happens when you're faced with a stressor. And a stressor can be anything, an expectation, having to fulfill an obligation, people asking you questions and you can't answer them. That can be stressful. So they become vulnerable because they can't process it the way they used to. Well, when you can't process it or make sense of it, or you're struggling and you know, the dots just don't line up and nothing seems to be working right, you're going to experience some behavioral and psychological symptoms. Okay, so even without anything else, just the fact that there is a disease happening and changing how the brain cells speak to one another, that can be a factor. Now, these are the same kind of issues as were in the previous slide, again, just organized a little differently, because they will come into play and affect how vulnerable and therefore how does the person respond to a situation. So we have them here organized as patient factors. What we talked about, the personality. Okay, so somebody's premorbid personality, any acute medical problems, So somebody might be doing quite well, and then they get a urinary tract infection. With a UTI, they become delirious. When they become delirious, they start to hallucinate. If you can treat the UTI, oftentimes they'll improve, things will stabilize, they might go back to their baseline of where they were at before. So acute medical problems will come into play and really potentially upset the apple cart. We're going to talk a little bit about unmet needs in a bigger model. But if somebody needs something and cannot get that need met, it's human nature to try to get it met. And when you try to get it met, you might be exhibiting some of these behavioral and psychological symptoms. So we have the disease, we have all the patient-related factors, then we have kind of the support and caregivers. How stressed is the caregiver? How depressed is the caregiver? How much does the caregiver understand about dementia? And that's why some of these things are so important, because it is hard to understand. How well, sometimes at the best of times, we don't communicate very well with one another. Families, in dyads, with friends, colleagues, there's miscommunication. When those things happen, that can accentuate some of the difficulties. When there's a mismatch between what the person can do and what is expected of them in the environment, when those two things don't line up, that's going to create stress. And stress, they're vulnerable to stress, therefore they're going to experience or express behavioral and psychological symptoms. Then there's the whole basic environment. What's the environment like? Is it overstimulating? Is it understimulating? Are there safety issues? Is there, again, like a lack of activity would be understimulation? Is there no routine? Kind of what's happening in the environment that potentially could be contributing. So these are factors that can influence that. And these are factors that one can look at when one's trying to address some of the behavioral and psychological symptoms. It gives us a starting point. So when somebody comes in and says, you know, my mom was doing really great and suddenly she's hallucinating. Well, the first thing we do is we look for you look for an infection, you look for something you can fix. So knowing these things gives us a point to start and ask questions. Could it be the environment? Could it be an unmet need? So it's a point of question to maybe try to find something that might help with whatever's going on. So the biggest thing is there's usually not one single cause. Again, if we're lucky and it's an infection and we treat the infection and everything gets better, that's great. But most times it's a combination of things. And therefore, while we start with the medical and the biological, because if it's something that's easily identified and treated, you want to get that. It's the logical place to start, but it wouldn't be the place to stop. Because if you've tested everything and everything is normal, then you got to go to the other factors and try to see what might be going on. So we're going to talk about some of those models. I mentioned the unmet needs model. The progressively lowered stress threshold model, I don't think I have a specific slide for that. I think it's just more generic. We'll talk about that. We'll talk about the unmet need, and then we'll talk about what we call the ABC model. Okay, so it's just ways of framing why the person might be expressing these behavioral and psychological symptoms. So if we think of the progressively lowered stress model, what happens, as I mentioned in the previous slide, the fact that there is a disease changing the brain chemistry, changing how well the brain cells can talk to one another, the person's ability to deal with stress or what's happening or expected of them is reduced. And that will cause stress. So if you think of your brain, now there are different diseases, different forms of dementia will kind of start and affect different parts of the brain. So they're not all the same. But one of the most important parts of our brain is the frontal lobe. Your frontal lobe is the last one to develop. That's why teenagers make bad decisions. That's why they're impulsive. That's why they're moody. That's not quite fully plump and developed yet. They say about 21, 22 before we're kind of fully connected to the frontal lobe. But it's the manager. It's what's last to develop, but it's the one that helps us kind of function at our high level. It helps us with decisions. It's how we can anticipate outcomes. It's how we can problem solve. It's how we learn social rules, what to say, what not to say, that's appropriate, that wasn't. It can, we learn to inhibit certain things. We learn to plan and organize and be flexible, figure out a goal. And today I want to do this, therefore I got to do this, this, and that. And then I'll get that done by 2 o'clock. And then I should be able to relax. That's goal-directed behavior. Having insight and self-awareness of what happened. I made a mistake. I forgot. I didn't. That self-awareness can be lost over time in dementia where a person really legitimately does not think there's anything wrong. There's no insight. That's kind of all frontal. Now, all the brain pieces are all very intimately connected with numerous brain cells, so they all talk to one another. But if things are affecting this and all of this becomes dysregulated, then it's going to be dysregulated. And that's where you're going to see the behavioral and psychological symptoms. So, as I said, different dementias will affect different brain areas. As any disease progresses, it will expand, it will progress, and will affect other abilities and other parts of the brain as well. And that's why, as we get to the more advanced stages of dementia, you're more likely to see some of the difficulties. Yeah, so all of the perceptual networks, how we perceive the environment visually, auditory, how we make sense of it, how we pay attention, all of those things will contribute to the BPSDs. So that is, oh no, we're still in it. So we were talking about the reduced threshold model, the fact that all these changes make it harder to cope with the world, okay? So all of these brain changes happen. All of these things will start to be a little bit dysregulated. I don't want to get into neurotransmitters because even I will drown. However, this is just some examples. So we know that the brain cells change. Brain cells use neurochemicals to speak to one another. That's how they communicate. If the brain cells are changing due to a disease, their ability to put out these neurotransmitters or use them when they're sent their way is changed. If you think of just these 4 here, serotonin is important for things like stabilizing our mood, reducing depression. It helps regulate anxiety. So if some of the nerve cells are having trouble keeping up and not producing enough serotonin, that's why we start to see some of the problems appear. If your dopamine is a bit dysregulated, again, that's important in mood, motivation, voluntary movement. Dopamine is one of the main factors in Parkinson's disease. Acetylcholine is very important for memory. It's what the memory medications, so the Aricept that we prescribe for people with Alzheimer's disease, is a cholinesterase inhibitor. It helps have more acetylcholine in the brain because that's important to memory and learning. Norepinephrine is important to stress reaction, energy level, attention. All that to say that when these cells can't function normally, they can't use these things normally. Therefore, you're going to have dysregulation in all these things. Okay? So the changes in the brain in and of themselves can precipitate some of the behavioral and psychological symptoms. Okay, so that's the reduced threshold stress model. Any questions? We're all okay? Okay. All right. The unmet needs model That one puts the unmet needs in the middle because that's what this model would think is the reason for the person's behavioral or psychological symptoms. So we have that in the middle, and what might influence what might be a need for that person, because everyone will have different needs. So it could be their lifelong habits and their personality. Who you are and what you're coming with will affect what you want out of life or out of a situation, your needs. Also, your current condition, your physical condition, your mental condition might influence what needs you have at that moment. And the environment might create certain needs. So all of those things will come in and then might create a need for the person. If that person is struggling to communicate that need or express or meet the need themselves, that would foster behavioral and psychological symptoms. So the behavior that you're noticing might be a way of either fulfilling the need on their own. So if someone is frightened, one of the biggest issues in hospital long-term care is the call bells. Always the ringing of the call bells and trying to get to the call bells and the answering of the call bells. So if I'm a patient with dementia and I'm afraid because I believe, I don't know, someone's in my room, and the way to get help is to push the buzzer because the nurse comes and provides me with some reassurance, well, I'm going to keep ringing that buzzer. And so I have a need because I'm frightened and I can't meet that need on my own. I need you to provide reassurance. So I'm going to keep ringing the buzzer. And that's how I am getting my need met, by repetitively doing this behavior. It might be a way of communicating a need. If people are having trouble speaking, so if they have certain degrees of aphasia, or they're word searching, or they're just really struggling to express what they might want, well, maybe the behavior is a way of communicating that. I'm trying to think of an example off the top of my head. Say someone can't communicate that they need to use the washroom, and they might do something. Maybe they stand up and pull down their trousers, which we would think, hey, that's not appropriate. I'm trying to communicate to you that I need to go to the washroom. That might be the only way I can figure out to say it. So there's the behavior, but it's a way of me trying to communicate to you that I have a need that right now I can't meet. Some of you might have great examples. If you do, jump in. Behaviors can just simply be an outcome of frustration or, negative, negative emotion. If I am angry and I have dementia and I can't communicate that anger, maybe I'm just going to pound my fist on that tray over and over again just because I'm angry. It's not how we would normally want someone to express anger, or we might start that way and then hope to be able to talk it out. But if you can't talk it out, maybe that's how you're expressing your anger. So the idea is to always, when you see a behavior, to stop and think, okay, is there something that this person is trying to tell me? Is there a need that this is either trying to tell me about or fulfilling on its own? Because then if you can identify that, and if you can find a more or a less disruptive way of meeting the need, you could potentially curtail the behavior that has been troublesome. Now, that makes it sound really easy, and it's not. It's not. It just gives you somewhere to start and at least an angle to work from. All right, so that's the unmet need model. We okay with that? Okay. The ABC model is easy to remember. ABC stands for antecedent, what came first, what is the behavior, and what is the consequence. So you think of a chain of events that happen. And this is basic behavioral psychology. Something happens, there's a trigger, there's a behavior, and there's a consequence. And if that consequence is reinforcing, then the behavior will remain or will increase. That's how you encourage more behavior. If you want somebody to do something and you give them a chocolate every time they do it, they're going to keep doing it because they're like, wow, this is really great. I'm going to keep doing that. So you have to think of this chain of events and try to figure out, again, it's to give you a point to start from to say, what is the chain here? What is it? It might not be obvious. What is happening? And is there a way where I can break the chain or change the components of the chain so that the middle part is changed to something that is, again, less disruptive? And sometimes the behavior doesn't go away. But sometimes if you can reduce, and I'm talking about, they're undesirable. We're talking about BPSDs. These are undesirable behaviors. If you can cut the frequency in half or the intensity in half, that's a win. That's a win. It might not go away, but it might get to a point where it is manageable and not so disruptive. But that's what you're doing. You're looking for the chain of events that happen, okay? The key is to try to avoid positively reinforcing unwanted behaviors. So positively reinforcing means giving something the person wants for a behavior that you don't want. And you have to try to, there's different ways in behavioral practice to try to maybe give the positive reinforcement for an alternate behavior. If you can identify what is reinforcing to the person and what the person really likes and wants and give it to them for a behavior that is different, then you could encourage the alternate behavior. So you're playing with things. Or if you can identify, so you can play with the consequences, or you can play with what comes first. If there's a behavior that's happening and you can analyze it and figure out, this happens every time the phone rings. Like, it's the phone. This ringer really seems to agitate my dad. And if you can really figure that out, well, then maybe you can figure out what the trigger is and get rid of it. Turn it off, find a new ringer, and then, oh, okay, well, that's better. Again, it sounds simple. Sometimes finding the triggers is hard, and sometimes they can't be eliminated, right? But again, they can be reduced or modified. When people are in the very advanced stages of dementia in long-term care, things like bathing and dressing become very, very stressful, and usually are really a situation where the nursing staff might have great difficulty with behaviors, physical aggression, things like that. So again, we have to ask ourselves, well, this is the trigger. We want to provide proper care for the person, but is there a way for this person that might trigger less of a response to what needs to be done to take the best care of them? And nurses will work and say, he loves the soaker tub. We can't sponge bathe him, but he loves the soaker tub. Okay, well then we use the soaker tub because that doesn't seem to trigger as much of an issue. It could be the reverse. We can't put him in the tub, but we can sponge bathe. So if you can identify, there's a way to modify to try to make the person or create less of a response to what needs to happen. When you're working, so when you're on your own at home trying to figure it out, it's often not easy and it can change with time. When you're in an institution, whether it's long-term care or a hospital, one of the hardest parts of implementing a behavioral plan, because that's what we call them. So if there's responsive and troublesome behaviors on a unit, you have to figure out how to fix it. So there's often a behavioral team that will go in who specialize in this. But that requires a lot of observation. So we need to get all the nursing staff on board at all shifts, because we have to analyze what's going on first. I can't figure out the chain of events. It might seem obvious, but sometimes you find out when you really look at it, it's not what you thought it was. So to make sure you're correcting the right thing, you have to get a baseline assessment of what it is that's happening. How often is Mr. Smith ringing the bell? When? At what time? What are the circumstances? You want to pull all that information together. That requires cooperation from the team. That means every nurse, everybody has got to be contributing to their shift and what they observed. That requires a lot of commitment. Then if you figure it out and you say, well, we think it's this, so here's the strategy, here's the plan. Every time this happens, we do this, we don't do that, you have to do this. And you have to do it consistently, because the one thing about behavioral training we know is that if you're inconsistent, you're going to be all over the place. So that requires commitment from the team as well. That's why oftentimes in some of the specialty, like the memory care units, or some of the retirement homes or long-term care facilities or hospitals that have special units and expertise, they will be much better versed in this sort of thing, and they will come together much more easily as a team because that's what they do. That's their specialty. So if it's hard for a team to do, I understand it's going to be hard for people at home to do. But you have the advantage of always being the one on shift and knowing what's kind of going on from day to day. So it gives you, again, somewhere to start and think about, how can I possibly deal with this behavior or psychological issue? And all of that is important because that'll be important for your well-being as well as the person with dementia and the relationships. This is an example of car driving, okay? The whole thing is about attributional theory, okay? When something negative happens, so you're driving along the highway, somebody cuts you off in an unsafe way and really makes you mad. If your first thought in your mind is, oh my God, that person must be having some kind of medical emergency, like that's not normal, you're going to feel badly for them. You're going to be much more tolerant of it. And you're going to, just have a different emotional reaction than if you think they were doing it on purpose and they're just a crazy driver, because then you're mad. And then it's, their fault and whatnot. So how you frame what's happening and try to understand it, while it might not provide an easy solution and an easy fix, it gives you a point to start, but it also can help reframe your interpretation of it. So by thinking, okay, it's the brain changes. Okay, there's not enough neurotransmitter. Okay, the demands are too high. If you're using it like that, that emotional reaction is different. Okay, so that's where this kind of thing can help as well. All right. By not understanding what happens, we can, misunderstand them, misattribute them to a different cause, feel differently about them, and then, of course, react or respond in a way that is counterproductive. But you're all human. It's going to happen. No matter how much you read about this, it's going to happen. All right. Okay. Any questions? Because we're going to move into some of the kind of the different behavioral and psychological symptoms in different dementias. Okay. We're all okay? All right. So this is just a slide to show that in this particular study from 2017, when they looked at over 100 patients, close to 99% had at least one behavioral or psychological symptom. So it just kind of ties to the beginning where it is going to be a common occurrence. And 71% had more than 4. So just because you're depressed, maybe a little disinhibited, doesn't mean you can't be anxious and that you won't maybe develop hallucinations. You can have a mix and match. What are the most common ones that we hear about are apathy and agitation. And those are broad terms. Agitation on its own, you can pick up different books and it'll be described differently. But we'll get into that a little bit. But apathy, agitation, irritability, sleep changes, mood disorders, disinhibition might be less frequent, especially in the early kind of mild moderate. It might happen later on, except in frontotemporal dementia, because frontotemporal dementia, by definition, because it's that frontal lobe that's mostly affected, they don't come in with memory complaints. They come in with behavior changes. That's their first symptom. So things like disinhibition and kind of odd social behavior, things like that. That'll be the first manifestations, whereas that might only come very late in somebody, say, with Alzheimer's disease. It might not occur earlier on. Dementia with Lewy body, we'll talk about that one because they have also kind of a little bit of a unique profile. All of them, as we said, were more prominent as the dementia severity increased. And of course, the higher the BPSDs, the higher the caregiver stress. So we're going to start with Alzheimer's disease. Alzheimer's disease is the most common form of dementia. It's the one we hear about the most, talk about the most, and have probably researched the most. This is just a slide to show you. So we have, it's always mild, moderate, severe, mild, moderate, severe, mild, moderate, severe. Okay, and these are the different kind of BPSDs that can happen. So you see, as I said, apathy is one of the most common issues, even in the mild stages. Of course, it gets worse as the dementia advances. Dysphoria is sadness, agitation is the other one. So this is what I was getting at. The agitation, apathy, disinhibition can be there, but it's less prominent in that type of disorder in Alzheimer's disease. So this is just one study, one slide. There's different ones, but it just emphasizes that things like certainly delusions can occur in Alzheimer's disease. It certainly does, but not usually at the same level or intensity. And hallucinations are not at all common, not as common. So if someone comes to the clinic and I'm assessing them and the family and the patient are reporting kind of newer changes that have been going on in the last year or so, and one of the first things is hallucinations that they've never had before, because we make sure they didn't have a psychiatric disorder to begin with. My first thought is not Alzheimer's disease, because that would be not typical early on. If I'm seeing somebody in the advanced stages and they're saying my mom is confused and she's delusional, she thinks we're all stealing from her, then that doesn't necessarily not fit with Alzheimer's disease. So we can use some of those things that come up to help us kind of maybe differentiate with what we think might be going on. So this is Alzheimer's. So now we're going to talk about apathy, which is one of the most common ones, probably across many of the dementias, but of course in Alzheimer's disease. So apathy is without emotion. It's a flatness. And we're going to talk about the difference with depression. So what can happen is there is a loss of motivation, a loss of interest. Things will happen and the person's emotional response is blunted. It's muted. It's not what you would have normally expected from that person. They can seem a little indifferent, and they don't initiate a whole lot. So that can be some of the things that people come in and say, well, my mom, she seems a little bit forgetful, but she doesn't do what she used to do. She doesn't go out anymore. She doesn't seem as interested in things. Now, of course, we're going to wonder, could it be that the person is depressed and sad and lonely? Those things could be true. That can be treated. That we want to get on if we think it's that. But sometimes they think, I think she's depressed, but then it's not depression. It's just one of these behavioral or psychological symptoms. So apathy, very common in Alzheimer's disease. It can be one of the dominant symptoms that show up, maybe 40% in mild, but as it advances, it gets more notable. So where do apathy and depression collide? Because they do overlap. So there is a set of overlapping symptoms. There are things that happen when it's more apathy, what we would call kind of brain-related kind of apathy, just those signals are not going the way they should. So that frontal lobe is not, goal-directed and initiating and strategizing. And then we have more the emotional side of depression. And it's these symptoms here that will often help us figure out, is there a depression? You can have a very real depressive disorder, even though you have dementia. And just because you have a dementia doesn't mean we don't want to treat your depression. Because if there's two layers to the problem and you can peel away one layer and the person feels much better and is functioning better, you want to do that. But so people come in and talk about the apathy symptoms, not participating, reduced initiation, unless somebody goes and gets them. Oh, my mom will go shopping if I go get her and, get her in the car. And then once we're out, she's pretty good, but she doesn't go anymore on her own. She won't initiate. She doesn't call me to go. She used to go with her friend. So kind of if you go and pull them out and make them go, they're less interested. They don't start activities. They seem a little indifferent. That can happen. It can happen in depression. And we would want to inquire then, is there an emotional component? Because with depression, there will usually be a sadness, tearfulness. Oftentimes people who are suffering with major depression will express feelings of guilt, even though they might not have anything to feel guilty about. They carry around a burden of guilt. They feel helpless. They feel hopeless about the future, and they can articulate that. Why do I feel hopeless? They're pessimistic. They might have suicidal thoughts. I don't want to live anymore. When someone can articulate all of that and is having that, then you would want to treat them for depression. But sometimes you have this flat person who doesn't initiate anything, who is not experiencing any of that. Then you would think, okay, well, then I think this is probably part and parcel of their dementia, or maybe one of the early signs of their dementia. Okay, so these become very important in trying to tease apart those two. Because like I said, this can be treated, and we want to get on that if we think that should be treated. Yes?
The line in it says diminished emotional reactivity. What would that look like?
Just that, like I said, something happens and you're expecting the person to respond either very happily or very sadly, or maybe even very angry. And they're just kind of more blunted. They just might get, okay, oh, well, that happened. And you're like, wow, okay, well, I thought that was going to be a much different, or someone dies and you're expecting the person to be very sad and they're like, oh, you're like, okay, well, this was a good friend of yours, and just not reacting in the same way as would be typical for them. Okay. Okay, so that's kind of the difference between apathy and depression. Oh, and I think, yeah, a good point up here. Apathy is a disorder of motivation, and depression is a disorder of mood. Okay, and that's where we want to try to tease apart what's going on with the person. Now, apathy and inability are not the same thing. So if somebody is not initiating, lacks initiation, is not really exhibiting any kind of goal-directed behavior, they might still have the ability to do that task or activity. So just because they don't doesn't mean they can't. It's finding a way to keep them engaged in certain things. Because most people I speak to are saying, well, I want to help my mom, but I don't want to overdo it because I don't want to overtake her independence. Where do I know how much to help, how much to leave to her own devices? And again, I don't have the magic answer because everyone's circumstances are a little different. And that's what you have to kind of figure out within your own relationship, kind of what works and what doesn't. So that's where mom might not go shopping unless I go get her, but once she's out, she can go, she can pick a new item, she can go to the cashier, pay for it herself, and that's a good thing. Just because they don't doesn't mean they can't. So to the extent possible, we do try to get people to remain engaged and active in their own activities. But then you're walking the line between creating too much stress, because as I said, if the expectations don't fit with what the person can do, then you're going to create stress and then probably a responsive behavior. That's where you've got to kind of figure things out. And you'll just get it figured out. And, 6 months later, it'll be a different thing altogether. Okay. All right. Moving on to anxiety and agitation. That's also a very common behavioral and psychological symptom in dementia. And agitation is different. So agitation is this, one definition is this excessive without a purpose. So no purpose, purposeless motor activity. There might be a sense of internal tension, but pacing without really any purpose, fidgeting, those types of agitated behaviors where there is no purpose, it's motor activity, and it just creates tension. Okay. It can become quite significant, but that's somebody who's anxious might also look a little agitated. When we're nervous or stressed, of course we pace as we try to figure out what to do. What am I going to do? Again, you want to get into the more emotional side of things. Are they just agitated? Maybe there's an unmet need that's going on. Maybe there's something. Or is it anxiety that can be worked through? Like, what are they worried about? If the person can say, I'm really worried about this, I'm afraid this might happen, I'm a little apprehensive about going to this outing, then that's psychological anxiety. That's something that can be, you would, address differently than just, I'm just agitated because I can't figure things out. Okay. Sundowning is a term I'm sure you have all heard. It comes across, usually there's this phenomenon that seems to happen where there's increased agitation later on during the day for different reasons, usually related to fatigue, changes in light. Of course, with changes of light in the evening, there's increased shadows. People with dementia can have kind of their internal clock can be a little disrupted. So sundowning is something you'll hear where the level of agitation or confusion might increase later in the day. Did you have a question? You didn't have, I thought you didn't have a question? No, okay. All right. Depression, well, like clinical depression, the mood disorder can co-occur. It's a common symptom, often an early symptom. Women might be more vulnerable, but that's not to say at all that men are not. And if you're depressed on top of having Alzheimer's disease, legitimately depressed, that is going to create more negative impact on your daily functioning. So people who don't have dementia, who are clinically depressed, don't have motivation, don't engage, feel sad, they withdraw, they let things go, you get overwhelmed, so all of that functioning is affected. If you put the two of them together, it's even more affected. And if we can treat it and help with daily functioning and reduce problematic behaviors and reduce caregiver stress, then that can help. So again, sometimes people come to us and it's not unreasonable for us to see someone you know, a year and a half. And they might say, this has been going on for a year and a half. And we went to the family doctor and we wondered if he or she was depressed. And we tried to treat depression first. That's not an unreasonable approach. You start with what can be treated and then see. So often the question can become, was this depression or is it dementia? And there's a few clues that we use to help guide us when we're assessing things. So again, there's an overlap. Sleep disturbances, changes in appetite, a little bit of apathy, kind of slowing things down, being irritable. That can be either or. But what might help us differentiate is often depression might come on a little faster than mostly Alzheimer's disease is a slowly progressive. So it'll be slow symptoms. They'll have this persistent sadness, whereas dementia patients might experience sundowning. So they tend to be worse later in the day. People with depression tend to be worse in the morning. That get up and go has gone and left. So it takes a lot to get motivated to decide I'm going to get out of bed today and maybe get dressed and maybe try to tackle something because I really just don't have it in me. So they can be worse in the morning. It's not always the case, but it's kind of some of the things we might ask about. As I said, those feelings of guilt, suicidal thoughts, and do they respond to SSRIs? Those are the antidepressants that affect the serotonin system. Whereas people with dementia, when they come in, they'll describe it much more as a gradual onset. Language difficulties, everyone who sits in front of me searches for names. I search for names. Everybody says, I can't find names. I can't think of words. That's a very common complaint, but not always a true impairment when I test it. It's normal. We all can't think of a name sometimes. When it is a true problem, if I have someone sitting in front of me and they truly cannot speak and they have anomia and aphasia, that's not depression. That something's going on. And if they haven't had a stroke, then I'm thinking something's going on. So true language impairments are usually not something you would see in depression. We call them the 3 A's. Aphasia is a language disturbance. Agnosia is an inability to recognize things. And apraxia is an inability to execute certain movements. If you have those things, if I test you and you have those, I'm thinking you have a dementia, not a depression. These are what we call kind of organic, brain-related changes. If the person is disoriented, getting lost consistently, confused about the date, the time, getting mixed up, it can be, depression can be really bad. So you can have very severe depression and have what we would refer to as a pseudo dementia. Okay, so you can be really bad, but normally you wouldn't be disoriented. So these are some of the clues that kind of help us kind of figure out, okay, which one of these could be going on?
Sorry, what did you say then? Apraxia is inability to execute movements, but what's aphasia?
Aphasia is a language change. Yeah.
And then
agnosia is a lack of awareness. So you can have different so what we say anosagnosia is when the person has no insight. You can have a visual agnosia where people do not recognize what they see. So I can show people pictures and they will have absolutely no knowledge of what that is. That's not normal and that's not depression. Yes. Okay. All right. We're just going to touch very quickly on vascular dementia, which is another form of dementia. Due to having had multiple strokes, as they accumulate, the person can experience enough cognitive change that they develop dementia on the basis of those vascular changes. The issue with the behavioral and psychological symptoms in vascular dementia is that it kind of depends on where the stroke happens. So if somebody has a stroke in a certain area, they might experience different behavioral and psychological symptoms than somebody who has a stroke in a different area. So it's not quite as predictable as, say, what might be expected in Lewy body dementia or some of the symptoms that we look for and are part of the defined diagnosis. So that's in your slides. We're not going to spend a lot of time on that one just because it can change. However, things like emotional lability, so fluctuating emotions without really necessarily having the full context that you would think might precipitate that type of emotion. So just kind of a lot of sudden and intense emotional response, whether it be laughter or sadness or tearfulness. It might stop as suddenly as it starts. It might be completely inappropriate for the context that the person is in. And it might not fit with what's actually happening inside. Like that's not, might be, what they're expressing might not be the emotion that's going on. So they might be laughing and laughing and laughing. They might not actually be experiencing a great deal of joy. And that can happen in a number of different neurological conditions, including the stroke. So there's that control of the display of emotion or how it's expressed can be different. So that's something that comes up quite a bit after, you know, significant stroke or multiple strokes where you would have vascular dementia. Lewy body is a form of dementia where there are, by definition, behavioral and psychological symptoms. And those are the ones that we look for. So when we think of Alzheimer's disease, we know that those BPSDs can manifest as time goes on throughout the disorder. But when I'm diagnosing Alzheimer's disease, I'm looking for, you know, memory impairment. I'm looking for, you know, a certain type of memory impairment. I'm looking for, you know, maybe some language changes, maybe some early visual spatial, and a history that fits with that. I can make a diagnosis of Alzheimer's disease if all those pieces fit, knowing that that person could then go on to develop BPSDs. With Lewy body dementia, the BPSDs are part of the diagnosis. So they will experience them usually earlier in the course of their disease. Anxiety can be a very common one. So it just might be that there's this change in the level of anxiety that the person might be experiencing. But visual hallucinations are kind of a hallmark of early visual hallucinations in someone who does not have a history of psychotic disorder. Is at the top of my list of things I'm going to consider is going to be Lewy body. If you throw in some of the other changes that they might have, like falling, fluctuations, with kind of periods of acute confusion, you know, hallucinations. And if you throw in a REM sleep behavior disorder, which is people who act out their dreams, if you come in with all of that and you come in with cognitive changes and you throw in a little bit of slow movement and Parkinsonian symptoms, that's pretty much textbook Lewy body dementia. But you know, we might say, well, I'm suspicious for possibly Lewy body dementia, but the person lacks some of the hallmark features because they haven't had hallucinations yet, and I'm expecting that. So I think maybe they have Lewy body, but they don't quite fit because it should happen earlier on. Okay, so that'll be a flag for us in terms of differential diagnosis. So it's an early common symptom. Oftentimes, the hallucinations will be of people or animals. So there's a cat in the house, even though they don't have a cat. They are usually, the person will be aware of it and the person can have insight into that. I see a cat in that kitchen every day and I know we don't have a cat. I'm not afraid of the cat. I just see it and it's there. And they can be not necessarily, they can cope with what they know is not there. If somebody comes in with auditory hallucinations, okay, like I'm hearing voices, that's not typical of Lewy body. That would make me think something else. That's more typical of schizophrenia. People with Lewy body don't usually have auditory hallucinations. It's visual hallucinations. And as I said, they can become disturbing and frightening. I had someone who saw spiders. Well, nobody likes to see big spiders in their bedroom, no matter how calm you try to be. So she knew they're not real, but she still sees them. So she kind of avoids looking where she knows They usually are. So she was coping okay, but it's not fun to see. So for her, that was that. People who are seeing a friendly, fluffy kitten might not be as bothered by it. They can become bothersome and frightening. If you see people in your house and, you know, there's someone sitting on my couch every day, that can become disconcerting. All right, so early visual hallucinations or visual illusions, misperceptions. So the part of the visual system is just not interpreting the environment. So they might see something, it is there, they look outside, there is a tree and there are branches on that tree, but when they look at it, they see it as, I don't know, arms of like there's a man out in the yard. It's like, no, it's the tree. Well, I don't see the tree. Or I've had people say, well, when, you know, my husband's in the car and he's a passenger and we're going, he keeps thinking there's kids on the road, but it's construction cones. So there is an object there. It is just misperceived and misinterpreted, as opposed to there is nothing there and I'm seeing the spiders all over the floor of my bedroom. A what?
Something, but everybody will potentially see something different.
Yes, but the Rorschach is intentionally obscure, which allows you the free spirit of different interpretations. A road cone is a road cone is a road cone. We all know it's a road cone. So they just misinterpret that information. So that can be, so maybe they don't have frank hallucinations, but they are not perceiving things properly. Delusions can also occur more frequently earlier on in Lewy body. A delusion is a false belief that is firmly held despite evidence to the contrary. And you can provide all the evidence you want over and over and over again, and the person will not believe you. You are trying to provide a rational response to an irrational belief. Therefore, you can't change it. It's very hard. That stays stuck. It can happen earlier on. Common types of delusions will be paranoid delusions, being fearful, feeling people are after them. Delusional jealousy can come up. People believe their spouse is having an affair. Of course, the first question we ask is it possible that Bob's having an affair? I mean, it happens, but is it really, you know, not at all what's going on? Capgras syndrome is a syndrome that, I mean, we don't often see these things, but this is a syndrome where the person believes that another person has been replaced by an identical person. So you look like my daughter, but you're pretending to be my daughter. Like you're not my daughter, you just look like my daughter. That's a delusional belief, but you can't shake it. That's called Capgras syndrome. We don't often see those, but it does come up and we're like, wow, that's really interesting. As I mentioned, the REM sleep behavior disorder is something that happens in Lewy body dementia. So if somebody comes in and says they have that, I'm wondering. So when we all go to sleep and we go into REM sleep, there's a little switch that prevents us from acting out what you're dreaming. When that doesn't work and you have a REM sleep disorder, what will happen is what you're dreaming, you will act out. Most oftentimes they are aggressive dreams, fearful dreams, running, being beat up, beating somebody up. So we will hear things like, he's kicking me, punching me, I now have to sleep in a separate room, he's falling out of bed, he's knocked over the lamp, because people are just flailing and really having a lot of that behavior. It can become quite significant and the partner can get hurt. Like if somebody's really punching you, you're going to get hurt. So people will resort to having to sleep in separate rooms. And the person might be more confused when waking and they might remember, oh, I think I had a crazy dream, but they don't remember, they're not doing it deliberately. That has a high link with Lewy body dementia. Maybe not right now, because some people can have a REM sleep disorder for many years, but prognostically, there's an increased rate of Lewy body dementia in those individuals when they get older. And it might be prodromal, means kicking around for quite a while before things actually fully develop. So you might have that for a few years. So REM sleep behavior disorder. And again, if you understand that and know that that's what's happening, then you know your spouse is not beating you up on purpose. Remember, you have to attribute it to the right cause. Another thing with Lewy body dementia is there will be a lot of fluctuations. Now, every person coming in with any kind of dementia, like most of us, will have good days and bad days. But the fluctuations and the level of alertness will be more fluctuating in people with Lewy body than people, say, with Alzheimer's disease. So they will look more confused for minutes or hours periodically. It can occur at any time during the day, so it's not just like a sundowning situation. And it'll just be more like the good and the bad days that can happen to everybody will just seem to stand out a little bit more. So if somebody comes in again and I say, has visual hallucinations, is falling, has Parkinsonian, has a REM sleep disorder, and they're saying, yeah, like it's just like all over the place, sometimes pretty clear and other times not, that's another kind of tick mark on the sheet. They too can experience mood. So the apathy that can happen, depression can occur as well. Anxiety and aggression can, as it can occur in all dementias, can happen in Lewy body. All right, so that's Lewy body dementia. And I think that one's interesting because the BPSDs are such a prominent part of the actual diagnosis and occur earlier on than your standard Alzheimer's disease. Behavioral variant FTD, frontotemporal dementia, is another form of dementia where the BPSDs are part and parcel of the diagnosis and will occur early on. So frontotemporal dementia, because that frontal lobe is where the disease starts, they, as I said, they don't come in saying, my wife doesn't remember and she keeps repeating herself. It's, my wife is now behaving in a way that is completely inappropriate, completely out of character. Something's wrong. Now, you can have both types. You can have the type of frontotemporal dementia where they go completely apathetic. Okay, so she's not necessarily behaving inappropriately because she's not doing anything. Sit at home, there's no initiation. There's a loss of empathy for others. I had one patient who had she was young, and it usually occurs in younger people, so kind of the 50, 55, 60. It can occur older, but it's kind of, we think of it more in a younger group of people. And, you know, this person had a young child and had been injured, I think at a soccer game or something. And the response was completely atypical, like completely unconcerned, flat, whereas the husband's like, that's not her. Like, this is not who this person should be. When you have the flat, apathetic, no initiation, you have to ask yourself, is there an element of depression? So is the person also sad, hopeless, guilty, tearful? If not, then we're looking at probably an apathy and a flatness that might be related to a frontotemporal dementia. More often than not, we will see them as the opposite. So they are more, so they're exhibiting behaviors that are more striking. So the disinhibition, the impulsivity, the changes in eating habits. Think of unplugging the filter and all the things you'd love to do that we know we're not supposed to do. They do, because the filter is kind of off. And that will be the first symptoms of FTD. So inappropriate remarks, inappropriate jokes. I've had people urinating in public. I've had people shoplifting, uncharacteristic, like absolutely never, and all of a sudden getting arrested for shoplifting. Like, this is not who this person is. You'll get gambling, drinking, shoplifting, hypersexual behaviors. making comments to strangers, neighbors. I've had somebody who was renting a hotel room for pornography, like really things that are over the top in terms of frequency and their typical, behavior. They develop what we call hyperorality, so very fixated on overeating, changes in food preferences. There's usually a preference for sweets and carbohydrates. I have yet to see an FTD person overindulge on broccoli. Nobody seems to go for the broccoli, but everybody goes for the chips, the chocolates, the candies. That usually seems to be the case. Or dietary compulsions, where they will hyper focus on a food item. It was peanut butter or pineapples or pizza. The wife is like, that's all he'll eat is pizza. A breakfast, lunch, and supper. Breakfast, lunch, and supper, that's all we eat. Now, we all like to indulge now and again, but it becomes, we're like, this is like the person is not even straying from this. We can't get them to do anything different. So changes in eating behaviors, or what we call food fads, can be a sign of FTD. As I said, they can be apathetic. They're often self-centered. They will have no insight. So somebody with Alzheimer's disease, when it first starts to happen and they start to forget, they can feel anxious because they know they're starting to forget. And people can come in and tell me, I'm getting more forgetful and I'm worried about my memory. Because FTD attacks the frontal lobe, and that's the important part of self-awareness, oftentimes right from the get-go, they don't really think there's anything wrong. I don't know why everybody's so upset. I don't know why my wife is dragging me to this clinic. So what? So what if I did that? Big deal. They don't see a problem. So there can be a significant lack of insight. And they can develop what we call stereotyped behaviors, so repetitive, compulsive behaviors. And it can be, and you wouldn't diagnose them. This is not obsessive compulsive disorder, like the psychiatric disorder, but they are manifesting compulsive behaviors. And it can be repetitive movements. It can be, all the things that, an OCD person might do, but they're doing it for a different reason. Personal neglect. So people will, all the social things. I mean, you shower, you change your clothes, you don't wear the same clothes every day, all day. And they might get fixated on, I am wearing, and that you just can't get them changed out of anything. So a loss of personal hygiene, lack of care of one's appearance that are uncharacteristic for that individual. Okay, so that's FTD. So the behavioral and psychological symptoms are right there in your face, and they're usually the first things to start. Parkinson's disease, again, that too will often come with more mood and anxiety sometimes in the early stages. So they can experience depression and anxiety. They don't have as much of a striking BPSD profile as say Lewy body or frontotemporal dementia. They're kind of more similar to the others. But psychosis can happen in Parkinson's. Now, there is an overlap between Lewy body and Parkinson's because people with Lewy body will often develop Parkinsonian kind of symptoms. But usually we say if you have cognitive problems first, cognitive perceptual problems first, and then you develop Parkinsonian symptoms, so slowing, stiffness, some of the motor signs of Parkinson's, then if you have the REM sleep disorder and the hallucinations, you would have probably Lewy body dementia. People who have diagnosed Parkinson's disease usually start with the motor symptoms prior to the cognitive symptoms. And if you've had your motor symptoms and your Parkinson's for a couple of years, usually 2 years, before you start to develop cognitive changes, because it is a disorder of the brain, so you're going to have some changes, then we would say you have Parkinson's disease with associated cognitive loss or dementia. But they do overlap, and there can be, and most oftentimes it wouldn't be unusual if you did an autopsy on someone's brain that they might have mixed pathology. They might have a little bit of the changes that we call Alzheimer's disease. They might have a few Lewy body proteins in there. You can sometimes have a mixed presentation. Okay, so in summary, I think so Alzheimer's is kind of our prototype of what happens because it's the most common form of dementia. Vascular is the one that's the least predictable because it kind of depends on where the strokes happen. Lewy body and frontotemporal dementia are the interesting ones in that the BPSDs are far most usually earlier on and part of the diagnostic criteria. And those are kind of the ones that we reviewed. So in conclusion, we doing okay? Yeah, in conclusion, so the key is to, again, to try to think of things from an angle that help with how you feel and respond as a caregiver or as a person with dementia, and how any of these troublesome behavioral or psychological symptoms can be interpreted and therefore may be potentially addressed. So difficult behaviors displayed by a person living with dementia are usually symptoms of a changing brain. It doesn't mean that they lose all their I mean, there are times when, especially earlier on, that's just who they are. I mean, people had fights before they had dementia. People had disagreements or miscommunications before they had dementia. Those things don't necessarily go away, but as the dementia progresses, the person's brain is just not functioning the way it used to. Sometimes the person really does not have full awareness of these behavioral problems, and they really can't maybe articulate why or what's going on or what would help. You have to figure it out. Planning ahead and learning how to manage the behaviors will help ease the difficult journey. So I've given you some models, some points of reference to think about. I do not by any means mean to imply that it's an easy fix, because it's not. If it was, I'd be out of work. A lot of people would be out of work. It would be easy peasy. We wouldn't need to do this. But at least it's a starting point. And again, if it just helps kind of change the interpretation of it, it can ease a little bit. Next week, or is it next week, or I don't know, is it every week? Yeah, you're going to get into the second part of this, and the next speaker will go over ways of much more detailed ways of treating and dealing with the behavioral and psychological symptoms. So tonight it was kind of a what they are, when they happen, how can you conceptualize them. The next speaker will get into more concrete strategies on how to deal with them. But in general sense, you know, there are pharmacological treatments, so medications do work. There are very good indications for certain dosages or types of medications to help with these behaviors. But also we always do try, the idea is always you treat you provide the least amount of medication as needed to treat the problem. So if you can get into behavioral interventions, breaking that chain of ABC or figuring out an unmet need where you don't need a medication, then that's a win. So we try to use behavioral interventions, and of course relying on community resources to help with support. We try to not have the medications as the first line treatment, because of course the older you are, and then if you have dementia on top of it, you're more vulnerable to the potential side effects of medications. But it is not to say that they are not appropriate and well used in some circumstances. We always say start low and go slow. So you really want the minimum effective dose. And again, we try to address the causes. We try to deal with use non-pharmacological strategies. And then if we have to, they do have a place. And I think, folks, that's it.
Right.
Okay.
Right,
Any
so-
questions, comments?
Yes, so if you also have a question, I'm happy also to take the question on the microphone so people can hear your question. Everybody can listen.
It was riveting. There's no question.
No question. Wow, everybody is so clear about it. Wow. All right. Have a question? No? Okay, let's see if we have any question online. I think we have a couple minutes left. So yeah, so there's a question about what are the most common triggers related to the ABC model?
Oh, goodness. It can be virtually any trigger. And that's where you have to, that's why we do the analysis. You have to spend some time figuring out the actual sequence of events. Because if you don't put the work up front to figure out what is the trigger in your situation, then you're going to be setting up a plan and you're going to be trying to change the wrong thing, and therefore you're not going to have success. So analyzing at the front end. But triggers can be anything. They can be physical, it can be pain, it can be noise, it can be virtually anything really. And things you might not think of. Like I said, you might not realize until you pay attention that that thing happens prior to every time this happens. And only then do you realize, my God, that's the trigger. That's the trigger, really? Let's try and change it. So it can be virtually anything.
Okay. So we have another question here. Are the physical symptoms associated with Alzheimer's, such as decreased mobility and others?
Usually that would come later. So as people advance to the severe and advanced stages of dementia, it's very hard to tease apart because you need the history of what's kind of started, right? So somebody who has very advanced Lewy body dementia and somebody who has very advanced Alzheimer's disease is going to be very hard. If I didn't know their diagnosis, I could not assess them at that point in time and tell you what's what. It's really what happened first, what symptoms did they have, how did they evolve? Motor symptoms and physical changes are not usually part and parcel of what we would think of in traditional Alzheimer's disease. People with Parkinson's, people with Lewy body. Now, people can have a mixture of vascular and Alzheimer's disease. So if you've had a couple of little strokes, which are affecting your mobility or your balance, and you also have Alzheimer's, you're going to have both things going on. But traditionally, physical motor changes are not apparent early in Alzheimer's disease. It will occur later, but not usually earlier on.
Okay, I can see here, if someone has a really good day, is that indicative of their potential that can be reinforced? Or is that just a recipe for caretaker frustration?
If you have a happy day, if things go well, what is,
Is it indicative of their potential that can be reinforced?
I think if you do have a really good day, the same way if you have a bad day and you need to change that, right? So if you have these undesirable events and behaviors and you have to ask yourself, well, okay, what's the trigger because I need this to stop? It's okay to also look back, wow, we had a really good day. Why did we have a good day? Well, what did we do differently? Oh, we didn't do this, we added that, we didn't have a visit from so-and-so, and it's like, okay, well, maybe I can try this again. Will you be frustrated because you can't replicate it? Maybe, but maybe you'll stumble on something that you have removed or added that has contributed to a good day. So good or bad, if you stop and analyze it, you're going to have more information and you're armed with something that either you want to do more of or less of to see. Will it always be the perfect, you just might not end up with the same outcome all the time. It just might be a stroke of luck that you just had a good day.
I think this question is more related to treatments, probably. Well, I'll read it for you. So does a person with more advanced Lewy body but not major Parkinson's symptom need to be on Cinemet?
Oh, that is more of a neurology question.
Neurology question,
Yeah,
right?
yeah.
Okay, yeah. So I can definitely keep this question and send it to the doctors that talk about treatment last week. Anyone else has another question for Dr. Sweet? All right. Well, it was lovely to have you here at in-house and also online. Thank you again for attending, and I'll see you next week. It's the last session, so keep the handout. So it's the same handout for next session. Next session, we have Dr. Lori Delmalva talking about management
Lori's
of
there.
behaviors. So with that, I wish you have a great evening and stay well and drive safe. Bye now.
Thanks, everyone. You'll love Lori. She's great.